Hello, everybody. Can you hear me?
Loud
Yes.
and clear.
All right, wonderful. I uh, I don't see Liliana. I think Dr. Martos is unfortunately busy with trauma while he's on call. Um, are there a few volunteers who can help with the panel today?
Sure, I can.
Thanks, Dr. Poost. Anybody else? No other takers?
I'm sure Dr. Kaufman is also available.
I'm going to be running out to Burn shortly. I will offer what I can, but
Okay.
I didn't want to leave in the middle.
All right, thank you. Okay. All right. Well, please feel free to offer your commentary. I did build in some breaks to discuss the clinical management of the patient, but I'll go ahead and I'll get started here. So my name is Matt Fleming. I'm one of the fellows here at Ryder in my second year, and this is a case from about a month ago. I don't have any disclosures. The learning objectives are to discuss some of the operative approaches for thoracic vascular injuries, evaluate some resuscitation goals in trauma, and then talk about acute respiratory failure in our trauma patients. So this patient is a 17-year-old male. He had a gunshot wound to the left chest, about the medial clavicle. The EMS transport said his blood pressure in the field when they picked him up was 80s over palpable, and he got a liter of fluids in transit to our level 2 trauma center, where he arrived in our trauma bay. On primary survey, his airway was patent. He was complaining of difficulty breathing and felt short of breath. He had decreased breath sounds on the left side. Our initial blood pressure was in the 80s as well, and a heart rate of around 120 to 130. He did have a palpable left radial pulse as well as left carotid pulse. He was able to follow commands and move everything normally, and despite being in distress. And on exposure, he had a ballistic injury to the left upper chest, just above the medial clavicle. And then on the left back scapula area. So just pictorially, sort of where the injury was here on the anterior side. And then, sorry, it should be on the left side here. So both apertures were on the left side of the body. So I can tell you what we did, or we can pause here. I will say that we did do an EFAST. He did not have any fluid around the heart. The pericardial views were negative, and he did not have any lung sliding on the left side. So we were suspicious for, hemopneumothorax on that side. Dr. Booth, should I just continue?
Yeah, just very brief. I mean, obviously the patient is tachycardic and hypotensive, right? So it's either from a tension pneumothorax or from hemorrhage or both combined. So to place an immediate left side chest tube before any imaging would be, in my mind, the appropriate step to do.
Yeah.
And at the same time, start transfusion, especially depending on what the chest tube is putting out. So, there shouldn't be no chest X-ray done or any other imaging until a chest tube is placed in the specific patient. Many things happen parallel in trauma, right? So I think it's appropriate at the same time that somebody takes the ultrasound probe and looks at the heart and stuff. but based just on the fact that he has a penetrating injury to the left chest and absent breath sounds and is hemodynamically unstable, he should get a chest tube immediately.
Yeah, absolutely. That is what we did. He got a left-sided chest tube. We did give him a couple units, 2 units of blood right away, which he responded to transiently. So he was given 2 units of red blood cells. Blood pressure increased to about 100. His heart rate came down slightly. And he was intubated at the same time as we put this left chest tube in. This put out immediately about 1,100 cc's, or just over a liter of blood. And no obvious retained foreign body. The endotracheal tube here looks to be an appropriate position, but you can see maybe some layering on top of the lung border here. As I mentioned, his pericardial fast was negative. At that time, we did activate the massive transfusion protocol. We got another 200 cc's of blood in the chest tube. We do have point of care labs available at that facility, and his base deficit was -11. His hematocrit was 33, and his pH was 7.1. A right femoral introducer was placed, and he was given an additional 3 units of red blood cells and 4 of FFP to try to maintain a 1-to-1 transfusion ratio. At that time, his blood pressure had actually improved to the 140, and his heart rate came down into the 90s. We can talk more about the decision to treat with the CTA, but as I mentioned, clinically, he had a radial pulse that was palpable on the left side, as well as a carotid pulse that was palpable. The aperture in the back was more inferior relative to the aperture, just above the medial clavicle. So concerned for subclavian vertebral injury there. We did do a quick ultrasound of the left neck just with the point of care machine, and there was no, jugular vein or obvious carotid injury that we could see. There was just a big hematoma there in the neck, in the sort of base of the neck and up supraclavicular area. So he was transported rapidly to CT scan, where we got a CTA of the neck and chest. I'll show you the axial views first. And then I come back up here. I can play this again. So you see nice opacification of the left IJ as well as the left common carotid. There's a lot of air. And then as we get into the chest here, see the lung laceration and subcutaneous air and hematoma adjacent to the scapula. Unfortunately, he was injected on the left side. So there's some artifact and streaking here from the contrast bolus. So that was a learning point for me, not to inject patients on the same side as their injury. And then I'll just show you, you can see nicely subclavian arteries here. I'll show you better on the coronals in a second.
And Matt, at the beginning, you made note that there was a left radial pulse. Was
Yeah.
it the equal to the right side?
We didn't take the time to do like a brachial index, but it seemed grossly, equal.
Thank you.
So here you can see, we had low concern for a major arterial injury, excuse me, and you can see that the subclavian appears intact here. As I mentioned, he was injected on the left, like in the left AC antecubital fossa. And so I'll just pause it there, but you can see there's a lot of streaking here from the contrast bolus. There's a hematoma there and air. It looks to be that the IJ here is, intact going down into the brachiocephalic, but it was hard for us to tell whether there was a laceration there. So, obviously he has a lung laceration and a hemothorax and a pneumothorax here and the posterior rib fracture. So we were, kind of deciding, if it was a vascular injury, we were planning to consult vascular surgery for an arterial, for help with the arterial reconstruction. But this seemed to suggest that the artery was fine. We were now concerned more with the subclavian vein injury. The chest tube really didn't put out a lot more since it was placed. However, it does seem like his left chest did still have quite a lot of blood in it, based on this CT scan. So as I mentioned, there's a left upper lobe lung laceration. We didn't see a significant arterial injury, and we were concerned for a subclavian vein injury. In retrospect, could we have performed, a quick delay, 20 or 30 seconds after the first CTA? Maybe that would have helped us figure out what was going on. But we didn't do that, unfortunately. Because of the increased amount of blood in the left chest, we did feel that he would need, the operating room. At this point, we had run serial point of care testing, and he was a transient responder to the transfusions. And with a progressively worsening hematocrit and a base deficit, despite what ended up being, I think, 5 of red blood cells and 4 of plasma in the trauma bay setting. I don't know if anyone wants to comment on what their preferred incision would be or how they would approach this case, given what I've shared already, but I think that's the meat of the discussion today.
Dr. Corwin, you want to go first?
Sorry, I was waiting for you.
Okay, go ahead.
I think yeah, given the trajectory and your clinical exam, my approach would have been different if I didn't have the CT scan, right? Because given the location, I'd have a higher suspicion for a vascular injury. Since it looks, this may all be attributed to the lung laceration, I would probably start with a left anterolateral thoracotomy. Do you disagree, Proust?
Yeah, I agree. I mean, you could have made an argument in the first go around to go straight to the operating room without a CT scan, right? Because the book answer is 1500 output from the chest tube, immediate output, mandatory thoracotomy, and you had about 1300, and the chest X-ray looked pretty good after you placed the chest tube, but you see on the CAT scan there's more blood in the chest, and that's often the case that the chest tube doesn't drain in everything. And the one thing we have to be careful when we put this chest tubes that we put them posterior, because sometimes they're anterior to the lung or in the fissure and they don't drain everything. And you think, oh, look, my chest tube output was only 1 liter, but in reality, they lost 2 liters of blood.
Right.
So I think you can totally make an argument, not even do a CT scan and go straight for thoracotomy just on the initial finding of an unstable patient, and the chest tube output of 1300 would be perfectly fine, right, to go to the OR. Now, it's also not unreasonable to do the CT scan. You did because the patient responded to the transfusion at that time. He was hemodynamically improved, his heart rate came down and everything. And you get additional information, concerns of vascular injury and how it would change your approach. Let's say if you have a subclavian or not, but if you would have crashed in CAT scan, then you would be sorry that you went to CT scan, right? So it's, it's not wrong, but always you have to keep in mind that those patients' status can change quickly, and when you're tied up in the CT scanner. Now it's as you mentioned, you have the contrast on the same side, so it gives you a lot of artifacts. So it's a little hard to say for sure if the artery is intact or not. It looks like, but you can't tell for sure. The same with the vein, right?
Yeah.
So at this point, I would be more concerned about bleeding from the lung, and go for thoracotomy. I would probably rotate the patient a little bit. Put a gel foam or rolled up blanket underneath him, so you're not completely lateral, but probably like 30 or 45 degrees turned a little bit, so you can go a little bit more posterior. And then I would stay a little bit higher than usual. I mean, at least fifth or maybe even fourth intercostal space, if you need to get to the subclavian vessels. But I definitely agree with going to the operating room. I think there's no road to go to IR here, as I have this there as an option, because we're bleeding from the lung, the patient's hemodynamic status is not good. So I would agree with Dr. Kaufman and proceed with a left anterolateral thoracotomy and probably rotate the patient a little bit more than just supine.
Yeah, thank you, both. So that was essentially the same discussion that we had. We did proceed immediately to the operating room, given that he was a transient responder. We did put a few bumps under the left side to try and elevate that. We did a typical sort of fifth intercostal space thoracotomy. I think in retrospect, you're right, a higher one would have been a little bit more useful. He had about 1 liter to 1.5 liters of clot in his chest. We did identify an upper lung laceration as we suspected, and repaired that with a 3.0 running proline suture, and did not appreciate any air leaks. We did note the violation of the pleura interiorly and posteriorly, which initially everything was hemostatic. He did have about a 2 to 3 centimeter laceration noted in the left phrenic nerve. So the trajectory of the bullet seemed to go, and the blast effect seemed to go straight through the phrenic nerve. It appeared that the recurrent laryngeal was intact around the arch from what we could see. We were irrigating the chest out and checking for air leaks from our pulmonary repair when suddenly significant hemorrhage came from the apex of the left chest. And we were able to get some sponges and hold pressure. But at that time, we felt that we needed more proximal access. So we performed
Matt, before you go there.
Yeah.
How if the bleeding was venous? Was it dark blood or was it arterial blood, or was it kind of mixed of both?
It looked venous. It was dark and seemed low pressure.
And could you control it by digital compression, just holding pressure?
We could, but it was not punctate. It was, it seemed like it was in the area of the laceration of the violation of the pleura from the blast effect or the trajectory of the bullet. And we were low, so it didn't seem, we had done this fifth intercostal, thoracotomy, so it would have been almost impossible to try and repair anything just with the angle and how much of the upper chest we would have had to retract out of the way.
So your thought was like this coming from the subclavian?
Yeah.
And out of curiosity, sorry for interrupting, but you made mention that the contrast bolus was given on the same side. Had you gotten access contralaterally?
Yeah.
Or was he getting his high volume infusion on that same side still?
Yeah, so initially he was getting some transfusions in that left side, the left arm, but we did place a right femoral introducer in recess, so that's where the majority of the blood transfusions went. But he did get maybe 1 to 2 units in that left arm.
Got it. Thank you.
Yeah, I mean, that's definitely kind of a mistake, right? Because even if he has a little bit of clot there, right, and now you transfuse on that side, you increase the venous pressure,
Hmm.
and it may, cause more bleeding. So it's always
Absolutely.
important, obviously, to stay away from it. My question was it kind of a track it was bleeding out? Like, could you put in like a Foley balloon and inflate it to do a balloon tamponade, or was just like the whole apex of the pleural cavity kind of blown out?
The whole apex was kind of like blown out, just kind of above the clavicle, and it was not, like it would have been. I think maybe we could have done it, but the angle of the patient would have had to be at, and how far away we were from the apex, given our traditional thoracotomy, it would have been really hard to dissect this area out more thoroughly. I think we did get good control just with, manual compression with a sponge. So we felt that we had time to do the sternotomy and supraclavicular extension. But I don't think it would have been really treacherous to try to expose this more from inside the thoracotomy. But I have read, especially, the Foley balloon can be a useful technique for these injuries. So we did proceed with the sternotomy and the supraclavicular extension. The muscle attachments, the SCM were taken down, and we encountered, as you'd expect, a large hematoma, but we were able to identify the jugular vein and follow this inferiorly and then laterally down to the junction with the subclavian vein, where we identified a laceration to the undersurface of the subclavian vein. That was the source of the issues. This was controlled with an Alice clamp and then repaired with 3/0 Prolene suture. Initially, we thought we had ligated it completely, but then we did identify that there was maybe about 30% narrowing of the vein, but it seemed open. This area was carefully irrigated, and we did end up tying off the IMAs and not identifying any other sources of bleeding here. He had stabilized. I think he only got another 1 to 2 units of red blood cells and 1 of FFP in the operating room. And so his chest was irrigated. The sternotomy incisions were irrigated. We closed the sternotomy with traditional sternal wires and closed the thoracotomy in layers, and then took him to the ICU intubated, and he was hemodynamically normal at that time. We did unfortunately violate the pleura of the right chest during the sternotomy. So we placed a right-sided chest tube, and we placed a angled inferior left chest tube and a straight posterior left chest tube. So this was our post-operative chest x-ray. So you can see the sternal wires, the right-sided chest tube here. He's got the posterior apical left chest tube. And then because of the diaphragm, I think this chest tube flipped up, but this is the angled inferior chest tube. I'll go over his ICU course a little bit more in detail, but essentially he was intubated and sedated. He needed a few products based on his tag to correct his coagulopathy, but he was hemodynamically normal, was making a good urine output. He did have small air leaks on the left chest tube, but was tolerating the ventilator well. He did need a bit higher PEEP. He was on a PEEP of 10 initially, and then that was overnight. Surgery was overnight, and then the next day he was weaned to pressure support ventilation. So I'm going to pause a little bit now and talk about the exposures for these types of injuries. As Dr. Pusta and Dr. Kaufman mentioned, we chose the thoracotomy because we were concerned about bleeding from the lung, and that he was a transient responder. So we wanted to have access for proximal control as well as, good visualization of the left lung, given the persistent hemothorax. A thoracotomy with a clamshell obviously gives very good access to the proximal great vessels. For this, just above the medial clavicle, I think that would have been, like I was saying, a little bit too far away from where our injury was, and the right chest, was clear, so no reason to go in there. A sternotomy with the supraclavicular extension right off the bat could have been an option. He was unstable, so we didn't feel like that was the safest option in case we needed proximal control or we had significant, bleeding from the lung. So that's why we didn't choose that. And then, the one thing maybe we could have done was the thoracotomy and just do the supraclavicular incision alone, with or without, resection of the medial third of the clavicle. That would have probably given us good exposure to the area of concern. So I think, maybe that would have been worth a try, and we could have spared him the sternotomy. With the hindsight being 2020. And then this thoracotomy with the sternotomy and clavicular extension is what we chose. Any other thoughts or suggestions about the initial exposure?
Yeah, Matt, congratulations. It's a very good save. The area where you have the blue dot, right, the proximal subclavian vein, it's notoriously difficult to get to and to control. It's a very difficult area, and people who have operated, they know that. If it's more distal, you may be able to do an infraclavicular incision and get control just where the vein is coming underneath the bone and ligate it. But where you are, like close to the junction of the IJ, it's very difficult to get to, either from supraclavicular or from the chest. And you have to do whatever incision you have to do to stop the bleeding, right? It doesn't matter if you end up doing a sternotomy in addition to the thoracotomy, or if you just did a thoracotomy and then try to do a supra-infraclavicular approach, depending where the injury is in the subclavian vein. If you can put a Foley balloon tamponade in, it works pretty good on the venous injury, specifically. If it's a kind of a good track, it works, right? If everything is blown out, it doesn't work. But if you have a track, it works pretty good to give you hemostasis, and then you have more time to carefully dissect out and get to the injury. You did everything right. Whatever incision it takes to get to the bleeding and save the patient, and that's exactly what you did. And he did very well. So congratulations.
Thank you. Yeah, we did think about that. He was bleeding not out from the wounds, he was bleeding into the chest, as we learned. So, but I'll keep the Foley trick in the back pocket, definitely.
Right.
A lot of the early work on subclavian injuries. This is a big study out of South Africa. Dr. Dimitriades and his colleagues studied 228 patients who had injured subclavian vessels, slightly more venous injuries than arterial, but combined injuries were also fairly common. Obviously, these are devastating injuries. This was published in 1987, but 60% of these patients died prior to arriving to the hospital. If they made it, their operative mortality was 15%, and the venous injuries were slightly higher morbidity, probably because of the inability to constrict, and possibly the authors in this paper mentioned that air embolism may actually be a big issue for venous injuries. They suggested that chest x-ray and physical exam were fairly reliable for diagnosis, and that back in this day, angiograms were sort of the gold standard test for helping diagnose and then localize these types of injuries. Arterial injuries were repaired for 94% patients, and venous injuries were either repaired in 60% or ligated in 40%. This is an update from Dr. Dimitriades and colleagues in Los Angeles who reviewed 79 patients with axillary subclavian injuries in the mid-90s. This cohort had about 59 arterial injuries, 40 venous, and then 20 who had combined. Of the 18 that arrived without vital signs, there were no survivors. 58 of those patients underwent OR exploration. One with an arterial venous fistula had a stent placement, and then 2 were managed non-operatively who were stable. Excluding the patients who underwent resuscitative thoracotomy, there was a nearly 15%, so a similar rate of operative mortality, which was much higher in the venous group. This paper really focused on, the best exposure for these patients, and said that a clavicular incision was adequate in 50% of cases. However, 50% required sternotomy and or thoracotomy for additional exposure or related injuries. So, this was kind of echoes what our clinical experience was. These are some nice photos from the asset chapter showing the exact area of interest. Based on our CTA, we thought it was kind of in this left subclavian right next to the IJ, but on our ultrasound we could see that the IJ appeared to be normal, and just there was a large hematoma, kind of where that red circle was clinically, but he was not bleeding outwardly, just into the chest. This is a nice table from the trauma textbook by Feliciano, Maddox, and Moore, just sort of trying to spell out the best exposures for, all these great vessels in the chest that are injured. As I was sort of alluding to, the thoracotomy allowed us to fix the lung very easily with good visualization and, if needed, vascular control of the lung. And then we were also able to easily compress the subclavian vein, while we were gaining additional exposure. And he remained stable, fortunately, during this time, but you had proximal aortic access if needed. Certainly, doing the 2 different exposures requires additional hands and time and supplies. And the supraclavicular or infraclavicular extension do take some time to do. I think these are also some nice photos from the asset manual that just show the attachments here of the SCM and the neck muscles that you have to divide to get through to the IJ and then the subclavian vein. And then remember to the scaling fat pad can be a nice reference, but this is a little our field looked a lot, just like a big hematoma, and to remember that the phrenic nerve is going to be right there as well. You can see that here on this slide to the left here, and then a nice dissection out of the scalene fat pad, and then the subclavian artery here is being lifted up. The clavicle can be removed for proximal arterial access or venous access. So on the left side of the screen is the right-sided dissection, and on the left side on your right is the left-sided dissection. We did not need to remove the clavicle. I think because we had done our sternotomy, we were able to sort of elevate things up, and so we had pretty good exposure, but we identified the IJ and then followed that laterally to this area where the laceration occurred. And then the scalene muscle is there, and then the phrenic nerve is right there. So moving back to the patient, so he was switched to pressure support ventilation on the morning of postoperative day 1. His PEEP was weaned aggressively from 10 to 5 during the day, and he was then extubated to nasal cannula around 3 o'clock in the afternoon. About 24 hours later, the trauma team was called to see him with a chest x-ray that I'll show you in a second. He did not have any shortness of breath. He was having difficulty with pain control due to his multiple incisions and surgery. We worked with him on his incentive spirometry and deep breathing, gave him some nebulizers to try to treat any bronchospasms, and he was placed on BiPAP, bi-level positive pressure, for a few hours. The plan's to get a short interval chest x-ray. If it did not improve, plan was for intubation and bronchoscopy. So I'll show you the x-ray here. So this was later the morning of post-op day, sort of 0 into 1. This is the chest x-ray later that day after he was extubated. So there's no ET tube. You can see here that it looks like the left colon is very dilated, and that left diaphragm might be a little bit higher now that he's off of positive pressure. The x-ray of concern was our standard sort of morning ICU x-ray that shows what looks to be like a fairly sizable pneumothorax, and then maybe complete collapse of both the left upper and left lower lobes here, and then maybe he's a little bit twisted, but maybe some shifting of the right lung fields into the left side, suggesting some volume loss. So this was the chest x-ray, which is essentially the same, maybe slightly improved, but still with complete collapse, it looks like, of the left lung after a few hours of BiPAP. So then he was intubated with a plan for bronchoscopy. He was intubated on the second attempt, and the chest x-ray confirmed tracheal placement. At this time, he had profound desaturations to 40%. He was sedated well. He was being bagged using the bag valve mask with a high PEEP set initially to 10 and then 15 and then to 20. And he...
Matt, can I ask a question?
Yeah.
So he desated immediately after intubation?
Yeah, he was, at that time, it seemed like he was getting more labored. And they had tried some high flow nasal cannula, they had tried some BiPAP. And then around 11 in the morning, he was intubated. So this is the first chest x-ray. Just see the tip of the endotracheal tube here. His lung, improved there from an aeration standpoint. But
right. So
I'll get in.
So I would argue, right, if you have a complete collapse of the left lung, right, which the x-ray showed, I would not do BiPAP or high flow. I would just intubate the patient at that time, because after pulmonary trauma, right, that collapses either from clot, right, that there's thrombus or clot in the bronchial tree and you bled into it, or it's a big mucus plug, right?
Right.
But typically it doesn't come out just doing high flow nasal cannula or BiPAP. You're gonna need to do bronchoscopy. So I would just intubate and do a bronchoscopy from the get-go, rather than trying to improve this patient with BiPAP or so, because it's not going to work. It's going to fail, right? And then the thing regarding the confirmation of endotracheal tube placement, obviously, I'm sure you guys did capnography and confirmed that he has end-tidal CO2, because even if on the chest X-ray the ET tube projects over the trachea, right, doesn't necessarily mean it's in the trachea, right? It could be still esophageal intubation. If the patient desats, you want to make sure you have end-tidal CO2. But I'm sure that was done.
Yes, that was done. He was not hypercarbic, and they did have end-tidal CO2 on the monitor. His post-intubation chest x-rays is here. You can see, slight re-expansion of the left lung fields here now with lung markings. He remained very difficult to oxygenate. His SATs were in the 40s to 60% range. So he was sedated and paralyzed. A bedside ultrasound did not show any left-sided lung sliding. So another chest tube was placed with a big rush of air. His SAT slightly improved after that time, but didn't get much higher than 60 or 70%. An A-line and central venous catheter were placed. He continued to be bagged even though he was paralyzed without improving in SATs. His arterial oxygen level was between 60 and 70%. So after being intubated around 11, we were struggling for about an hour to oxygenate him. The ECMO team was consulted around noon, and they agreed he'd be a good candidate. But he was at a level 2 trauma center, which does not have those capabilities. So this required coordination of flying down the machine and the perfusionist with the ECMO staff to the hospital. In preparation for that, bilateral femoral venous catheters were placed. And then once the ECMO staff arrived, these were dilated up and he was cannulated and started on the ECMO circuit around 4 p.m. that day, post-op day 2. He SATs corrected to 100% after initiation of ECMO, and he was placed on rest settings on the ventilator, and then transported to Ryder Trauma, where we can handle the ECMO circuits. This patient, I think, had a number of factors that contributed to this. This is just a little bit sort of a summary of what was tried. With he was not the typical ARDS patient that we often manage in trauma or with significant blunt or penetrating chest trauma. He had gunshot to the subclavian vein and the upper left lung, and then collapsed his entire left lung. He also had a phrenic nerve injury that may have contributed to this. During the resuscitative efforts before ECMO was started, bedside echo did demonstrate grossly normal left ventricular and right ventricular function. But he, so we were considering a PE, but that seemed unlikely. I should mention that post-operatively, we did check an ultrasound of the left neck and left upper extremity to identify any deep venous thromboses, and we did not see any. So we did think his subclavian vein was open and not clotted at that time. Just kind of going into some of the differential diagnoses for this episode of respiratory failure. I think we always think of pulmonary embolism, especially in the polytrauma patients. They're at high risk. He was young. It seemed that a myocardial infarction would be unlikely. An air embolism, I think Dr. Dimitriades and his team discusses that. However, he was a few days after the gunshot wound, and this seemed unlikely. His upper airway obstruction, was he did he have oral pharyngeal trauma, either from intubation or something else? Did not seem like that. He was not stridorous. He didn't seem to have any edema on exam, and he was easy reintubation. He could have had pulmonary edema, certainly, from his resuscitation, but it seemed more likely mucus plug. I mentioned that colon was very dilated, so we did replace a nasogastric tube, but there was no history of aspiration that we knew of. Certainly, he could have aspirated at the time of the injury or in transport to our hospital. As I mentioned, he had multiple, painful incisions and multiple chest tubes. He was sort of splinting and asking frequently for pain medicine in the initial postoperative period. Now, we didn't learn until later, but he even though he's only 17, he was taking narcotics. And then he did have this left phrenic nerve injury, that probably some combination of all of these factors, led to his precipitous respiratory decline. His PEEP, initially we had some difficulty oxygenating him in the operating room, so he was kept on a PEEP of 10 post-operatively, and that was weaned to 5 within about 8 hours, so less than 24 hours from his initial operation. I think combination of all of these things led to the collapse of that left lung there. We're fortunate to have ECMO capabilities, our center. I know not everywhere is. Wanted to review a recent kind of clinical consensus. That would be a whole nother lecture to talk about ECMO and trauma, but briefly, there's no specific contraindications in trauma patients except irreversibility of injury. Even now, TBI or massive transfusion protocols are thought to be, not a definite contraindication. Vast majority of the patients that ECMO is used for are those with severe chest trauma, leading to severe pulmonary dysfunction. There are case reports and small series of ECMO being used to rescue trauma patients who are in cardiac arrest. But I think you need sort of defined protocols and a system that can do VA ECMO for those patients. The traditional inclusion criteria would be reversibility of injury and a relatively good prognosis, and then the PDAF ratio for severe ARDS. Patients that you've tried prone positioning or paralysis and who are not improving should get evaluated by an ECMO team. It's generally thought that earlier in this time course, especially with the severe chest trauma, that the outcomes, might be better, though that's not borne out in the literature. And then, we're always nervous about anticoagulating our trauma patients systemically. However, most of the circuits now can be run with a minimal anticoagulation, especially for veno-venous circuits, and you can monitor the oxygenator for clot burden. So, more interest and more user-friendly for patients. And some of the concerns that have traditionally been held for TBI patients and those who were massively resuscitated may be less of a concern, but certainly needs to be evaluated on a case-by-case basis. I won't go into his whole 3-week ICU course, but he was transferred to the Ryder Trauma Center after the ECMO cannulation. He did have multiple episodes of large mucus plugs to that left lung, so that I think is what it was. He required several bronchoscopies while on ECMO to re-expand the left lung, and he was also treated for ventilator-associated pneumonia. His paralysis and sedation and analgesia were rapidly weaned in the first couple of days being at Ryder, and then he had about a 5-day run of ECMO that was slowly weaned down. He tolerated that well, and he was decannulated and then actually extubated a few days after that. Currently, he's neurologically intact, walking around, eating, seems to have grossly normal function of the left upper extremity, and he just had his last chest tube removed this morning, so hopefully should be leaving the hospital shortly. I had a couple of sort of personal take-home points from this case. As I mentioned, the contrast was injected on the same side of his injury, which actually clinically hurt us. I think, maybe we could have moved to the operating room more swiftly had we injected on the right side. However, we never know. Maybe he wasn't bleeding at that time. Initially, when we closed the sternum, we forgot to place a right-sided chest tube, and so That was an error in judgment. And then, I think we had palpable carotid and radial pulses. So the arterial injury seemed unlikely just based on our physical exam, like Dr. Dimitriades and other papers have said. The physical exam can be very important. And I think now, if you have an ultrasound in the trauma bay too, you can, you can quickly use that as well. I think we may have been able to spare him a sternotomy. Next time, would I be brave enough to just do the supraclavicular extension and cut out the clavicle if necessary? I'm not sure, but it certainly, may have been a good patient for that. As our moderators said, try not to transfuse into the side of the arm and the injured side. Probably made his hemothorax worse. And then I think, his respiratory failure was certainly multifactorial. The phrenic nerve was injured. He did have a lung laceration. He had multiple large painful incisions. He was massively resuscitated in the first 8 hours or so. And I think he would have benefited potentially from a longer trial of pressure support. Although he ultimately did well. He did require rescue with ECMO for refractory hypoxemia. So I was going to stop there. I'm happy to take any other questions or clarifications.
Thank you, Matt. It was a beautiful presentation, very organized, very well thought through. I think we all learned a lot from it. It was a great rescue twice, right? Once in the operating room, you saved them from exsanguination. And then second, with great critical care, you were able to rescue him. Sometimes you were in a level 2 hospital where there was no ECMO capability. And it obviously, took some time to mobilize the team and get them over. And I see Dr. Parker is in the room now, so maybe you can give some comments as well as Dr. Matos, who was also involved in this case. Maybe you can give a brief comment on that. Sometimes when you have a patient who's hypoxic like this with complete collapse of one lung, you may be forced just to do a bronchoscopy at that time, even so he's hypoxic. Ambu-back venting and try to get in very quickly with the scope and see if you can get the mucus plugs open up on the left side. The right side is much easier, right? You can often just bring the suction catheter down and get it out of the suction catheter on the left side. Sometimes you just need the visualization with the bronchoscope, even so the patient is, very hypoxic, because you just have no options other than you're only going to get him better if you get the left lung opened up, right?
Right.
But maybe Dr. Parker can give some comments and Dr. Matos as well. Great save and great presentation. Thank you.
Thank you.
Hey,
Dr. Matos,
yes.
go ahead.
Yeah, so again, when I saw this patient in the morning, the patient was desating for already for a couple of hours, and then the situation, and again, and he was intubated, and by the ICU team, and they just could not rescue him. So the idea was to really go fast and try to, he's a young patient, try to see if your ECMO would be available to go over him, and then it was not a plug, and again, and Dr. Parker came right away, did the ECMO, and then was a life-saving procedure. He has some ideas about, and he can explain how ECMO works and what problem happened for this patient to go to situation. And Dr. Parker, are you there?
Yeah, I'm here. I'm sorry, I'm in a kind of a noisy environment, but thank you very much, Matt, for presenting that. And just as Dr. Marcos said, the medical team was all behind, rapid ECMO initiation. The administrative and the political world tends to move a little slower, but actually the 4 hours is not that bad compared to other cases that we've had to go down to the Jackson South at the level 2. Ultimately, the pathophysiology of the respiratory failure is, I think, a little bit multifactorial, given the mucus plugging and then also the high peaks that be required. Typically, ECMO does not treat anything in the sense that it's just resting the lungs, but this lung rest and did show signs of pretty rapid improvement of the compliance in the lungs. So I think that, we are dealing with, healthy compliant lungs on the right and a very injured plugged lung on the left, and those, high peak pressures led to some shunting. And after the PEEP was able to be weaned rapidly on ECMO with the hypoxia reversed, the compliance did improve pretty significantly. But yeah, I think it was a good presentation, Matt. Thank you. And yeah, absolutely, this kid has thankfully been saved twice now and doing very, very well, and hopefully they're in the hospital soon.
Matt, can I ask you one more question? The lung injury, you did a pneumorrhaphy, right? Was that fairly up peripheral in the left upper lobe, or was the injury relatively close to the hilum?
No, it was fairly peripheral. It was kind of the apex of the left upper lobe. And there was no tractotomy to perform. The bullet had already sort of performed the tractotomy for us. It was two sides of the left upper lobe that we just reapproximated together to close the tractotomy essentially.
Okay, thank you. All right, great case, great presentation. Thank you so much, and see everybody soon.
Thank you all.
Thanks, everybody.
Bye bye.